So after we do that calculation, 1800 divided by 2345, we get 0.767, so roughly 0.77, and we're just going to change that into a percentage, which would be about 77%. We want that value to be roughly 41% or above to suggest the patient's recruitable. Reason being is because normally functional residual capacity should be about 40% of your total lung capacity. If it's less than that, then it's just suggesting that patient does not have enough working functional residual capacity to be recruited, and or they're too stiff and at risk for damage to their lungs if we were to do a recruitment maneuver. So in this scenario, we do have a recruitable lung. It's not going to look exactly like the normal lungs would look because I just have a test lung with some PEEP added to the outside of it in order to kind of collapse it. The other things you'll notice is we have here a lower inflection point calculated. We can measure that separately with our different cursors. That's going to be on the inflation limb. And that's just going to be where you see that rapid rise in volume on the inflation limb. And then you have your point of de-recruitment, which is 14.6. It's automatically measuring it for you, but you can also use your cursors to measure it because it doesn't always capture it. That's on the deflation limb. That's just, those values are slightly different because we, after we've opened the lung up to total lung capacity, as the lung is slowly deflating, there's ideally more alveoli that have opened at that point. So a lot of people feel this is a slightly more accurate measurement. Some people will either choose one or the other, or kind of just find a happy medium of both. We also have our upper inflection point captured at that triangle, the upwards triangle. And that just shows us that essentially where we have very little change in volume at that point. So we should try to target our airway pressures 20 or below in this scenario. Since we have a recruitable lung, we're going to go to the next step, which is a recruitment maneuver. These settings default to have your pressure start at your current PEEP setting, stop at 40, because at 40 centimeters of water pressure for 10 seconds, which is where that pause is there, is where the most recruitment happens in the lungs. We have our ending PEEP as at 15. You can titrate this to obviously whatever the preference is by the physician, but the optimal PEEP in most patients has been found to be around 14 to 16 to keep the lungs open after they've been recruited. So with this maneuver, the goal is to recruit the patient with a recruitment maneuver and then keep them at an optimal PEEP setting to keep their lungs open. You could also set it to whatever your recommended optimal PEEP setting was, if you choose to do that. And then we also have a quicker ramp speed because we don't need to delay getting to that pressure top where that recruitment is happening. It kind of just shortens the recruitment maneuver, gets them to where they need to be in order to make things happen, and then brings them back down to their new PEEP setting. So then we'll hit start again. And you notice your PEEP changed to 15 because you set your new PEEP setting to 15. What you would assess here, normally you would have between the inflation and deflation limb on lungs that are more than just what my test lung is, which is technically just like one alveoli. You would see a change in volume between those two limbs. You would also see a squiggly line or like a stitching pattern, because as your lungs start to inflate with the recruitment maneuver, you have a drop in pressure as more alveoli are recruited. However, the ventilator is trying to achieve 40 for that entire 10 seconds, so you'll have a drop in pressure with a subsequent rise in pressure back to 40 to try to continue to recruit more lung. So you'll just see that stitching pattern there, and then typically you would measure the difference in those volumes between inflation and deflation limb using your two cursors. We're not going to see a huge difference here between inflation and deflation since we just have the one lung. So we're on our deflation side now. Right now, all we're seeing between these two numbers is a difference of 31.5. Typically, you would see at least a little more than that. In order to deem this a positive response or a positive recruitment maneuver, you would want that change in volume between inflation and deflation to be at least 2 mLs per kilo. Also, if you've titrated your FiO2 down as low as possible to get to roughly 92%, you'd want to see roughly a 5-point change in SpO2 after 5 minutes. But the more important change that you'd want to see is that 2 mLs per kilo and change in volume between inflation and deflation limb. And then that would suggest you've had a positive recruitment maneuver. From there, you just ideally would keep your PEEP setting where it is, wherever it's optimal for your patient, whether that's based on the recruitment maneuver that you, the assessment portion that you did, or just doing what the protocol suggests at 15, where your patient's most hemodynamically stable, or where their drive pressure is lowest. You would just keep them there until you've titrated your FiO2 as low as possible, ideally less than 50%, and then just slowly over time, based on physician and care plan guidance, you would slowly titrate that PEEP to what's optimal for that patient, but also to be able to liberate them from the ventilator. And as you see your patient's lungs improve and just kind of progress towards tolerating more spontaneous breathing, so on and so forth. So that is the PV tool.